Thank you very much for your patience in the delay of the start of the Ohio House Health Committee. For those of you watching at home, you probably realize we are in the final week for this GA and add lame duck in as well. So it's been a very interesting time, a lot of moving parts and pieces, and believe me, we owe it to you to get this right for you. And for the state representatives who have worked so hard for causes, we owe it to them to give their bills a just hearing as well. So that's really what we've been working on at this point. We are going to proceed this morning or this afternoon. The first order of business will be roll call.
Chairman Lips.
Here.
Vice Chair Holmes.
Here.
Ranking Member Boyd is excused. Representative Antoni.
Present.
Representative Butler.
Here.
Representative Carruthers.
Here.
Representative Kleitz.
Here.
Representative Catrona.
Here.
Representative Ginter.
Here.
Representative Grandel. Representative Keller.
Here.
Representative Lepore-Hagan is excused. Representative Liston.
Here.
Representative Plummer.
Here.
Representative Russo.
Here.
Representative Swearingen. Representative Upchurch is excused. Representative West is excused.
Having a quorum present, we will proceed as a full committee. The first item of business, we will be going out of order to assist state representatives or senators who are attending to work their bills. And we will be starting, our first bill is actually the last bill on your agenda today. We'll be starting with House Bill 620 and asking Representative Crowley to come forward. Representative, welcome to committee.
Thank you, Chair, for bringing this bill up first. Good afternoon, Chairman Lips, Ranking Member Boyd, and members of the Health Committee. Thank you for the opportunity to provide sponsored testimony on House Bill 620. House Bill 620 would task the Legislative Service Commission with conducting analysis of all bills to determine whether the proposed legislation will have a positive, adverse, or neutral impact on the health of Ohioans and on the attainment of health equity in the state. Health and equity in all policies is derived from the World Health Organization's Health in All Policies initiative. It is an innovative approach to creating and implementing public policies that systematically take into account the health implications of policy decisions. By emphasizing the need to collaborate across sectors to achieve common health goals, health equity in all policies is further defined as a change in the systems that determine how decision makers in local, state, and federal governments ensure that policies have neutral or beneficial impacts on the determinants of health. By broadening the scope of this concept through the addition of equity as a component, this policy will provide the state with a more critical look at the overall context in which Ohio's vulnerable populations are impacted by the social determinants of health, such as education, housing, safe neighborhoods, healthy foods, transportation, and employment. According to the economic research conducted by the Prevention Institute, investments in activities that were assessed for their impact on health and equity, such as creating physically active communities and increasing access to healthy foods, could result in a large return on investment in just a few years. With Ohio ranking 38th nationally on a composite measure of health value, adopting this common sense approach will help the state make great strides in improving health outcomes for all of Ohio's citizens. I would like to discuss the importance of this legislation in terms of our current events. We received word that multiple colleagues have tested positive for COVID-19. Over the summer, the governor tasked the Minority Health Strike Force team to look at the impacts of COVID-19 on Black and brown communities, as they have been adversely affected more than other groups with COVID-19 and have a mortality rate that is higher than other populations. We can see that with the report that came out of the Minority Strike Force team conducted by the governor, health equity in all policies was one of the recommendations made to the governor's administration in a way to address the inequities that different populations are impacted by. This legislation Also ties in with the House Concurrent Resolution 31, which declares racism as a public health crisis and promotes racial equity. The resolution recognizes the inequities in the healthcare system based on race and works to correct the biases while also advancing health equity. House Concurrent Resolution 31 also acknowledges the systemic racism and historical racism seen in redlining or inequitable school funding formula that negatively impacts current outcomes regarding health care, economic security, housing, and educational achievement. I will also say that House Bill 620, as well as House Concurrent Resolution 31, also takes into account that it's not just racism, but also economic status that impacts Ohioans that live in Appalachia, as well as the inner cities across the state of Ohio. There is definitive data that shows racism negatively influences health outcomes, and House Bill 620 works to identify certain legislation's health impact and determine which bills are not supportive of health equity. Again, having health impact statements would allow us as legislators to be more informed in not codifying discrimination in our policies. We are able to see whether a policy has a negative impact, a neutral impact, or a positive impact. So I do want to talk about, just briefly, the requirements of the bill. For the health impact statements will require a review process for bills. It will require the staff of LSC to review each bill introduced in the General Assembly and prepare health impact statements concerning the bill, just like we have for fiscal impact statements. It will require the health impact statements to analyze whether the bill, again, might have a positive, negative, or neutral impact on certain factors concerning health equity, and social determinants of health. It will require the establishment of a health and equity interagency team. It creates the Health and Equity Interagency Team in the Department of Health to ensure collaboration among all state agencies and requires every state agency to appoint a liaison to the team. It specifies duties for the team, including coordinating among state agencies to address health and equity factors impacted by the social determinants of health. It requires the team to submit an annual state health and health equity report to the Director of Health. I would also like to give a quick shout out to Shelley Duckworth, who's been working with my office and doing a lot of research on a health and equity interagency team at the local levels with health commissioners who are supportive of this bill and would like to work with the state and state agencies to promote health equity among populations all across Ohio. And so with that, Chairman Lips and members of the Health Committee, I would like to thank you for the opportunity to speak on behalf of House Bill 620. And at this time, I would be happy to answer any questions that you may have.
Representative, thank you for being with us, and thank you for your presentation. Committee members, questions? Representative Russo.
Thank you, Chair. Thank you, Representative, for introducing this legislation, which I think is incredibly important as we move forward and think about all of the factors influencing equity and access and in the provision of healthcare in particular, but also in our policies that we create here at the state level. I'm curious because I've heard this conversation, I think in some of my other work with colleagues across the country. Are there any other states that you're aware of that have moved far along in this process, who have done similar things? And I know several states are talking about this, but I wasn't sure how far along some may have gotten in this effort.
Absolutely. Through the chair to the representative, thank you for your question. So yes, the state of Washington has introduced and passed legislation for health impact statements. We see other states like Michigan, especially when it comes to Flint and their water quality issues, and the many issues that they've been dealing with over the years, as far as their infrastructure and lack of updating the infrastructure. They have also introduced legislation. I would like to say, I think we have Colorado and Massachusetts. Don't quote me on that, but I can get you that information. on the other states and what they have done. There are other states who have passed legislation that is specific to like construction, zones, and things of that nature that isn't just on every piece of legislation, but on very specific legislation and the impact of health that it might have, such as asthma, especially when we're constructing new roadways. And I can get that information to the chair, who can distribute it to the rest of the members.
Representatives, additional questions? Hearing none, Representative Crowley, thank you for being with us today.
Thank you.
This will constitute the first hearing on House Bill 620. Committee, the next bill on our agenda this afternoon will now be House Bill 503, Representative Mary Lightbody. Representative Lightbody, welcome to committee.
Thank you very much. I'm very glad to be here, and I appreciate the opportunity to share this legislation with you all. Chairman Lips, Vice Chair Holmes, Ranking Member Boyd, and fellow members of the Health Committee, thank you for allowing me to testify in support of House Bill 503 to protect minors by prohibiting certain licensed healthcare professionals from engaging in conversion therapy when treating minor patients. The purpose of this legislation is to protect Ohio's youth from conversion therapy, an outdated and dangerous practice directed at changing their sexual orientation and/or gender identity. It is based on the false claim that being LGBTQ+ is a mental illness that must be cured. This view has no scientific basis. The practice of conversion therapy is opposed by professional medical and mental health associations, including the American Medical Association, the American Psychological Association, and the American Academy of Pediatrics. 20 states and Washington, D.C. have laws banning conversion therapy for minors. Virginia was the most recent state to sign the law into effect in March of 2020. In addition, 7 cities in Ohio, Athens, Cincinnati, Columbus, Dayton, Kent, Lakewood, and Toledo, have banned conversion therapy as well. Ohio must step up to join these other states and localities in ending this practice and preventing future harm. My office worked with a number of partners, including Equality Ohio, the Human Rights Campaign, Equitas Health, Kaleidoscope Youth Center, the Mental Health and Addiction Advocacy Coalition, the National Association of Social Workers, the Ohio chapter, and the Ohio Psychological Association, and the Ohio School Psychologists Association to draft the language of this bill to include the healthcare areas that would be impacted. You will see a letter of support from Sam Brinton, the Vice President of Advocacy and Government Affairs at the Trevor Project, a national organization providing crisis intervention and suicide prevention services to LGBTQ youth under the age of 25. Human beings are complex, and each individual is unique. As children grow, we all learn about the world and develop an identity that expresses who we are at heart. This legislation affirms the right of young people to develop their own gender identity, gender expression, or sexual orientation without those in the medical community trying to change their minds. The medical team at the Trevor Project published a peer-reviewed article in the American Journal of Public Health in July 2020. It was the first study to look at the associations between undergoing conversion therapy and suicide outcomes among LGBTQ youth. The key findings of the study included LGBTQ youth who underwent conversion therapy were more than twice as likely to report having attempted suicide and more than 2.5 times more likely to report multiple suicide attempts in the past year compared to those who did not. These findings add empirical data to support the professional consensus that sexual orientation and gender identity conversion efforts are inappropriate and harmful. LGBTQ youth with lower family incomes, the study further determined, from the South, whose parents use religion to say negative things about those who are LGBTQ, those who are Hispanic or Latinx, who are transgender or non-binary, were overrepresented in the reports of undergoing conversion therapy. This data highlights that young people who report undergoing conversion therapy are not wait a minute, got my pages mixed up here. Sorry, I don't have them numbered, and that was clearly a mistake. A homogeneous population, but that efforts to address this issue must be inclusive in terms of the diversity of the identities affected. There are small signs of progress here in Ohio. The city of Westerville is in my district and recently joined Columbus and more than 24 Ohio municipalities to enact common sense ordinance protecting LGBTQ individuals and their families. We know that without any real statewide non-discrimination protections for sexual orientation, gender identity, or expression, we'll continue to see more of the same. Fewer businesses locating here and fewer young workers deciding to call Ohio home. But we can't continue to operate a patchwork of protections statewide. To grow pathways to the American dream, we need to continue to march towards equality by passing common sense legislation to benefit the hundreds of thousands of LGBT individuals and their families who live and work here. For Ohio's LGBTQ youth, that pathway to the American dream means being able to live the life they imagine for themselves. Now, health professionals may continue to assist patients with voluntary gender transitions, provide acceptance, support, and understanding, and facilitate a patient's coping, social support, or identity exploration and development. This legislation is not meant to be a limitation on legitimate medical and psychological practice. It is meant to protect our youth from dangerous practices from health professionals who are meant to be a source of trust for our young people. Thank you for the opportunity to testify in support of this important piece of legislation, and I'd be happy to answer any questions that you may have.
Representative Lightbody, thank you for your testimony today. Committee questions? Hearing none. Representative Lightbody, thank you for being with us and sharing this bill, and this will constitute the first hearing
Thank you very much.
on 503. The next item of business committee will be one of our own members, Representative Liston, presenting House Bill 315 for its sponsored testimony. Representative Liston, welcome to your own committee.
Thank you. I certainly feel like this is my committee, although I'm sure that other members would also take ownership as well. So thanks, everybody. Thank you, Chairman Lips, Ranking Member Boyd, who I know is virtually watching, and members of the House Health Committee for allowing me to present testimony on House Bill 315. This bill allows gun shop owners to take an active role in addressing the alarming suicide rate we're experiencing in our state and our country. In 2018, suicide was the 10th leading cause of death. And as we all heard in Rep. Russo's testimony last month, any suicide attempt is much more likely to result in a death if a gun is used, with an 85% suicide completion rate as opposed to 5% for other methods. More than half of all suicides occur using a gun, and 2/3 of all gun deaths are suicides, with men, youth, and veterans at particularly high risk. Across the country, gun retailers have realized that they can have an impact and save lives by providing suicide prevention information at the time of firearm purchase in their stores. This was started by a group that was formed, the New Hampshire Firearm Safety Coalition, after a gun store owner realized that in the course of 1 week, 3 people with no connection to each other had bought firearms and then committed suicide within hours of the purchase. The store owner began meeting with other firearm retailers and mental health professionals to explore the role of gun stores in preventing suicides. Their efforts resulted in a strong impact on the distribution of suicide prevention information within New Hampshire, and other states have started to follow suit. This particular bill, or this legislation overall, is an effort to build on the work in the state of Ohio, empowering gun retailers to be part of the solution. This particular bill quite simply asks gun stores to provide a brochure with suicide prevention information to individuals who come to purchase a gun. Should this bill move forward or gain more bipartisan support, I'd be happy to work with stakeholders to identify the best type of information. That New Hampshire Coalition has a number of materials that they created and the gun retailers in that state distribute or post. I think there's a lot of options whereby we can help empower multiple stakeholders with a lot of different viewpoints on this issue to help people in crisis. So I think we have an opportunity to do so and save lives by suicide. So thank you for your time. I welcome questions.
Representative Liston, thank you for your testimony and for bringing this bill to us. Committee questions? Representative Carruthers.
Thank you, Mr. Chairman. I just have one question. Have they noticed since they've done this that the numbers have dropped appreciably?
So I've seen a couple of studies. Truthfully, when I first introduced this bill, I had stakeholders come and show me that there was some information. I haven't been able to reproduce that. When I look at in terms of finding the exact study, when I go back to the New Hampshire, keep misstating that, Firearms Coalition, they present a lot of information on what the owners do and what percentage of people are getting information, but I don't know the numbers on what they've seen in terms of outcomes. Sure. Thank you for the question. Through the chair to the representative.
Committee, additional questions? Hearing none, this will members, I'd like to draw your attention to written testimony that you do have on this particular bill. And hearing no additional questions, we'll constitute this as the
I
Representative
apologize.
Liston.
Yes, I'm sorry. I do want to reference the other testimony. This particular issue is of significance to my office. The written testimony, I believe, is from my aide, who had personal experience with her own father, who did commit suicide using a gun when she was much younger. And so I think that we have a personal connection here to really try to work in this space and help individuals. So just wanted to give a shout out to Grace for being brave and submitting as well.
Yeah, thank you. You get to speak in your own committee, so on your own bill, so sorry I missed you. Representative
okay.
Ginter.
Thank you, Chairman, and thank you, Doctor, for your testimony. So you have started me down a vein of thinking in regards to, unfortunately, the types of instruments or whatever might be used for an individual to commit suicide and take their own life. My first question would be this. Do you know if there is any other entity, I guess I would use that phrase, in the state of Ohio that provides brochures or information similar to what this bill is projecting, that also gives information and a warning regarding suicide?
Through the representative, or excuse me, through the chair to the representative. So when we go back and think through what the most common suicide attempts are from, right? They're often overdose.
Right.
And certainly there are warnings on medications that, for example, on some of the antidepressant medications, there's warnings about the increased potential when you first start taking one that you might become a little bit more activated, which sometimes leads to people actually acting on a suicide plan. So there's warnings there. I'm not aware of a pamphlet that's given out. Typically that is a prescription from a physician or a clinician who then will talk through that risk with people. Mm-hmm. And obviously they receive mental health or are receiving some sort of mental health support and services, so should have that information. That's the only other place where I think that you're seeing an immediate impact, right? Hanging, stabbings, jumping in front of, there's not a lot of ways I think that we could bring other methods together.
Yes.
Quite the same way that we can here.
Follow up.
And again, more than half of completed suicides are with a gun.
Follow up. Thank you, Chairman. Thank you, Doctor. So perhaps we could have an offline conversation about this, because I do wonder if even with the medications, if it is in such bold print or it's so noticeable that an individual's attention is drawn to it, aside from the other, perhaps what we call side effects of that particular medication. And I'm wondering if that might not be a bad idea to hand out a separate brochure or something. But you've spent more time thinking about this than I, but I just wanted to have that little momentary conversation with you, and of course, perhaps in the future, we could talk about that even further.
Sure, I appreciate the input. I think any way that we can provide services and information about available services to people, especially those in crisis, is a good thing. So happy to continue the conversation. So.
Committee, additional questions? Representative Liston, thank you very much for being with us and sharing your testimony. This will constitute the first hearing on House Bill 315. Committee, the next item of business will be brief. It will be House Bill number 554, if you want to look at it on your iPads. It's up for its first hearing. Representatives Manchester and Representative Boggs asked to submit written testimony only, which is on your iPads. They will neither one be participating in committee today due to conflicts. So having asked each of you to read that testimony, this will constitute the first hearing on House Bill 554. Okay, the next item of business will be Senate Bill number 272, Senators Rogner and Blessing. This is a compact bill. We've been hearing several compact bills. They seem to be very popular across the country in individual disciplines at this time. Testifying on Senate Bill 272, I would like to ask Tanya Apke to come forward, please. I remember the card. Thank you very much for being with us in committee today.
Are you ready for me? Okay. Hello, and thank you for the opportunity to be here today. Chairman Lips, Vice Chairman Holmes, Ranking Member Boyd, and all members of the House Health Committee. My name is Dr. Tanya Apke, and I'm the current president of the Ohio Physical Therapy Association, and I'm also an assistant professor and the director of clinical education for the Doctor of Physical Therapy program at The Ohio State University. The OPTA is a state professional association representing physical therapists, physical therapist assistants, and physical therapy students in Ohio. On behalf of the OPTA, we are requesting your favorable consideration for Senate Bill 272, entering Ohio into the Physical Therapy Compact. As you heard in sponsor testimony last week, there are 29 other states who either have a fully operational PT Compact system or have passed their enabling legislation. There are also currently 2 additional states, including Ohio, that legislation is pending. This bill allows practice portability for licensees who live in a compact state. Compact activities in states surrounding Ohio are Kentucky, which have enacted their legislation, West Virginia also have enacted, Pennsylvania also enacted, and Michigan, where the legislation has also been introduced. According to the ptcompact.org, the Physical Therapy Compact is an agreement between member states to improve access to physical therapist services for the public by increasing the mobility of eligible physical therapy providers to work in multiple states. This is especially important for those clinicians who work in border cities such as Cincinnati and Toledo, where they could potentially work in multiple states. One example includes therapists who work for Cincinnati Children's Hospital Medical Center. They have clinics that are located on both sides of the river in both Ohio and Kentucky and could potentially work or cover at various clinics. Right now, they would need to be licensed separately in both Ohio and Kentucky. If Ohio joins the compact along with Kentucky, they would need just one license. The OPTA believes entering the compact will attract additional physical therapists to practice in Ohio, while also giving our current licensees added license portability in order to serve our patients. It will also make licensure more seamless for practicing PTs, allowing them to use their extensive skills more widely. The compact is also a useful tool in respect to telehealth. The COVID-19 crisis has demonstrated the need for telehealth utilization. The compact would allow more PTs to continue to treat their patients remotely. Also, obtaining compact privileges for licensees is much faster, easier, and less expensive than going through the current process if someone were to move or to be relocated. This legislation has broad support in Ohio and across the nation, particularly with our military PTs and their spouses. This legislation would decrease the cost and burden of moving into Ohio, which is especially important for our early career professionals whose student loan debt burden may affect their choice of practice locations. The OPTA has worked closely with the Occupational Therapy, Physical Therapy, and Athletic Trainers Board on this issue. The profession and regulators of our profession are fully supportive of Ohio entering the PT Compact. We are pleased to report to the House Health Committee that Senate Bill 272 received unanimous passage in the Ohio Senate. The bill did not receive any opposition testimony. The OPTA would also like to thank sponsoring Senators Regner and Blessing for their commitment and work on this issue. Thank you so much for your consideration, and the OPTA is excited to work with the General Assembly on moving Ohio towards becoming the next state to enter the compact. I'd be happy to answer any questions the committee might have. Thank you.
Dr. Apke, thank you for your presentation. Committee questions? I met with this organization several months ago to review this information and make sure the ramifications of the compact were good for Ohio, and they were 100% convinced, I will tell you. So they certainly shared their feelings and why this is so important for the future of this profession. Additionally, this, I want to remind you, came out of the House Senate with a unanimous vote. So thank you very much for being with us in committee today.
Thank you.
We also have Missy Anthony. Is Missy Anthony with us today for testimony? Ms. Anthony, thank you for being with us in committee today. You may proceed.
Good afternoon, Chair Lips, Vice Chair Adam Holmes, and Ranking Minority Member Janine Boyd, and members of the House Health Committee. My name is Missy Anthony. I'm the Executive Director of the Ohio Occupational Therapy, Physical Therapy, and Athletic Trainers Board, and it's my pleasure to be here today in support of the PT Compact legislation. The mission of the OTPTAT Board is to actively promote and protect the health of Ohioans through effective regulation of the professions of occupational therapy, physical therapy, athletic training, orthotics, prosthetics, and pedorthics. You can see I've listed in your testimony the 9 members of the PT section of the board, and they are from all parts of Ohio. The PT Compact will increase the ability to work across state lines in a responsible way to the benefit of members of the military, their spouses, traveling therapists, and for utilization in telehealth. Those are just a few examples. A compact privilege is relatively easy to obtain via the compact website, and it eases access for the physical therapy practitioner. The PT Compact itself requires all states who are members of the compact to conduct background checks and share information related to discipline, ensuring that all members of boards have similar standards related to public protection in place. And this is the key. It allows us to continue to make sure other states are conducting similar background checks, similar to Ohio's standards. The PT section of the OTPTAT board has carefully monitored the PT Compact's progress from its inception and development in 2014 to its enactment on April 25th, 2017, to its first issuance of privileges to practice on July 9th, 2018. According to the PT Compact Commission, approximately 200 compact privileges are issued each month, and a total of 1,826 privileges were issued between January and September 30th, 2020. And that is an uptick in the last year. They have seen a growth in compact privileges due to telehealth primarily. As the PT Compact is enacted in more states, it's currently 29 total, the board has fielded inquiries from therapists interested in seeing Ohio join. In particular, the PT Compact will assist physical therapists and physical therapist assistants who live and work in border states and who have patients who live across the border. The PT Compact will increase access to physical therapy for patients while keeping appropriate protections in place for the public. The fiscal note does a good job of describing the different factors that may impact operating revenue, and any impact should be manageable. That was an important issue for the board. The board strongly encourages passage of Senate Bill 272 during the current General Assembly. This bill has no opponents. Speedy passage will allow the board to get to work on implementation, which is expected to take around 6 months, maybe a little longer, due to some of the IT systems that need to learn to talk to each other. As telehealth expands during this COVID-19 emergency, and we expect that telehealth expansion to stay, this compact becomes more in demand. So thank you very much for your time, and I'm willing to answer any questions.
Ms. Anthony, thank you for your presentation. Committee questions? Representative Ginter.
Thank you, Chairman, and I'm not meaning to make this my day for questions, and I'm certainly thankful for the work the Chairman has done, and evidently the overwhelming vote over in the Senate, and thank you for your testimony. I'm trying to wrap my brain around this because we have a couple of compact bills that have hit our committee here recently. And and perhaps you can help me with, walk me through the practicality of this as to how it works in real life. So my understanding is there will be a physical therapy compact commission of which there will be representatives, if I understand it correctly, from Ohio on that commission. And then you've talked about the number of states that have already joined this compact. My question, I guess, is this. When there is I guess I have a couple questions. First of all, are there any significant differences in the practice, for example, of physical therapy between the state of Ohio and other states? And if so, how is that, how is there an agreement in regards to those differences as you join this compact?
Sure.
That question makes sense?
Absolutely. Representative Ginter, through the chair, to the committee, and Representative Ginter, we've tried to keep this simple. Bottom line, yes, there are differences in practice of PT between states. There are a couple of ways that we have acknowledged that and tried to deal with that through the compact. One is, the bottom line rule is whatever state you're practicing in, and that is determined by where the patient is located. So I'm a Kentucky therapist. My patient is maybe at home in Ohio in this era of telehealth that we have leapt into. I have to practice by the laws and rules of Ohio. So if there are things that I could do under my Kentucky license that I'm not permitted to do in Ohio, I'm not permitted to do them with that patient at that time. Additionally, Ohio requires a jurisprudence exam, which is an overview of our Practice Act, the Ohio laws and rules. And each person who gets a compact privilege will be required to take that exam so that they do have some depth of knowledge on how to access the rules and laws and what they are. So that would make sure that they are somewhat familiar with the practice of PT in Ohio. And there was one other thing I was going to say about that. Did I hit your questions?
I think you did. And so in other words, everyone that is a part of this compact has had to hit certain metrics in regards to physical therapy that would allow them to practice in the other states of which they have joined as a compact. But yet each state can retain their individuality and autonomy in regards to their practices. Does that make sense?
That is correct, Representative Ginter.
Okay.
The other thing I would add to that also is, just because there's a scope of practice that allows a physical therapist to do these things, if they're not prepared to or not trained to do some of those individual modalities, they still can't do them even if it's in the practice of the state of Ohio. It's kind of like the specialties of a physician, for example. So that is also an additional protection.
Thank you. Thank you, Chair.
Committee, additional questions? Representative Plummer.
Thanks, Chair. Thanks for testifying. Just a quick question. If you're in Kentucky, you have your license in Kentucky, and you use this compact to practice in Ohio, and there's an issue where you're not in compliance, who investigates that complaint? Your home state, or does Ohio investigate you if there's an issue with compliance?
Thank you, Representative Plummer, and to the committee. That's a very good question, and that is one reason the board waited for this to develop a little bit. We waited about a year or so to watch this thing, see how it would operate. There are two important points about that. One, it would matter kind of where the violation occurred. So if the Kentucky therapist with the Kentucky license, if an incident occurred in Kentucky, Kentucky would investigate that matter. If they chose to take disciplinary action on that Kentucky license, Ohio would find out about it, and we would be able to shut down the PT compact privilege, and that person would not be permitted to practice under their privilege in Ohio. In fact, the commission would shut down that privilege, and they wouldn't be able to practice in any of the states in which they had a compact privilege. On the other hand, under that example, if that Kentucky therapist were practicing with an Ohio patient, Ohio would conduct that investigation alongside with the help and cooperation. And that's one thing that this legislation requires, is that help and cooperation and sharing of information with the Kentucky board.
So if the action was so egregious, your Kentucky license, can Ohio withdraw your Kentucky license if it was that bad?
To Representative Plummer, to the committee, no, the Ohio board does not have jurisdiction over any other state's license.
So essentially, you would just go back to Kentucky, maintain your license, and not to be allowed to practice back in Ohio. Is that fair to say?
Representative Plummer, if the incident happened in Ohio, and Ohio investigated that incident and took action through the PT compact to shut down that privilege, that would in effect shut down the privilege to practice in any other state. Also, referral would be made to Kentucky, and Kentucky would take action.
Representatives, additional questions? Ms. Anthony, thank you for being with us today.
Thank you.
Is there anyone else in the audience wishing to testify on Senate Bill 272 today? Seeing none, what's the pleasure of the committee on this bill? Vice Chair Holmes.
Mr. Chairman, I move that Senate Bill 272 be favorably reported to the House Rules and Reference Committee.
Roll call.
Chairman Lips?
Yes.
Vice Chair Holmes?
Yes.
Ranking Member Boyd? Representative Montani? Yes. Representative Butler? Yes. Representative Carruthers? Yes. Representative Kleitz? Yes. Representative Catrona? Yes. Representative Ginter? Yes. Representative Grandel? Representative Keller? Yes. Representative Lepore-Hagan? Representative Liston? Yes. Representative Plummer? Yes. Representative Russo? Yes. Representative Swearingen? Yes. Representative Upchurch? Representative West?
With unanimous vote, committee, you have moved to favorably or voted to favorably report Senate Bill 272, the Rules and Reference Committee. The next item of business on our agenda will be House Bill 469. I now call House Bill 469 for its fifth hearing. Is there anyone in the audience that would like to testify on House Bill 469 today? Hearing none, that will conclude the fifth hearing on House Bill 469. At this time, committee is going to go to at ease for 10 minutes. Thank you. Thank you for bearing with us for that short 10-minute recess. Obviously, we had a discussion that took a little longer and was a little more complex than we had anticipated, so thank you very much for your patience. We would like to reconvene, and starting with Senate Bill 302, which is Senator Eklund and Senator Antonio's stroke patient protocol bill. You've recently heard that bill, so I think it's probably fresh in your mind. I now call amended Senate Bill 302 for its second hearing. Is there anyone in the audience who would like to testify to amended Senate Bill 302? Hearing none, what's the pleasure of the committee? Vice Chair Holmes.
Mr. Chairman, I move that amended Senate Bill 302 be favorably reported to the House Rules and Reference Committee.
Roll call.
Chairman Lips?
Yes.
Vice Chair Holmes?
Yes.
Ranking Member Boyd? Representative Antoni? Representative Butler? Representative Carruthers? Representative Kleitz? Representative Catrona? Representative Ginter? Representative Grandel? Representative Keller? Representative Lepore Hagan? Representative Liston? Representative Plummer? Representative Russo? Representative Swearingen? Representative Upchurch? Representative West?
A committee with unanimous vote, you have voted to send amended Senate Bill 302 to House Rules and Reference Committee. The next item of business on our agenda will be Senate Bill 260, which is Senator Huffman's bill regarding the R4U86 abortion procedure. I now call Senate Bill 260 for its second hearing. Are there any members of the audience that would like to testify on behalf of Senate Bill 260? Committee, I would like to draw your attention to several pieces of written testimony on your iPads for you to review. What's the pleasure of the committee? Vice Chair Holmes? Vice Chair Holmes?
Mr. Chairman, I move that the Senate bill be favorably reported to the House Rules and Reference Committee.
It's been moved that we vote on Senate Bill 260. Roll call?
Chairman Lips?
Yes.
Vice Chair Holmes? Ranking Member Boyd? Representative Antoni? Representative Butler? Representative Carruthers? Representative Kleitz? Representative Catrona? Representative Ginter? Representative Grandel? Representative Keller? Representative Lepore Hagan? Representative Liston? Representative Plummer? Representative Russo? Representative Swearingen? Representative Upchurch? Representative West?
A committee, by a vote of 10 to 3, you have favorably passed Senate Bill, amended Senate Bill 260, Senate Bill 260, to the House Rules and Reference Committee. The next item of business on our agenda will be HCR number 25, Representatives West and Representatives Upchurch. This will be a third hearing for all testimony, and we do have witnesses with us. At this time, I would like to call Andrew Shamus to testify. Can somebody go out and get Andrew Shamus? Oh, there you go. Mr. Shamus, welcome to committee. Thank you for being with us today.
Thank you, Chairman Lips, Vice Chairman Holmes, and members of the Health Committee. I thank you very much for giving me the opportunity to testify today. My name is Andrew Shamus, and I'm an associate professor in the Division of General Internal Medicine at The Ohio State University. I am speaking today for myself and not as an official representative of the university. Childhood trauma and its long-term effects on individuals and communities represent a major public health problem that has long gone unrecognized. Adverse childhood experiences include witnessing violence or abuse, witnessing violence in the home or community, having a family member die by suicide or homicide, growing up in a household with substance misuse, mental health problems, or instability due to an incarcerated or otherwise absent parent, or living in unsafe and under-resourced communities. The problem is surprisingly widespread. 61% of adults, which would be 5 million Ohioans, have experienced at least one adverse childhood event, and 1 in 6, 1.4 million Ohioans, has experienced 4 or more. The burden of adverse childhood events falls most heavily on communities of color as a result of both historical and contemporary patterns of racial discrimination. Adverse childhood events have a major impact on the present and future health status of affected children. They substantially increase the risk of sexually transmitted infection, teenage pregnancy, involvement in sex trafficking, and of chronic medical conditions like diabetes, cancer, and heart disease. Children subjected to toxic stress can suffer from problems such as poor attention span, severe anxiety, hypervigilance, impulsivity, and post-traumatic stress disorder. These problems often go unrecognized in schools, where children are labeled as having behavior problems and suffer undeserved academic and disciplinary consequences. These problems can have an enormous impact on job and economic opportunities, on relationships and life trajectory, and can be passed on to progeny in what is now known as generational trauma. When the psychological impact of trauma goes unrecognized and untreated, children, sadly, can grow up to recreate the conditions that traumatized them. In this way, over time, the problems of children become the problems of adults, of families, and of communities. These outcomes are not inevitable. We know that childhood trauma can be recognized and treated. With help, children can overcome the effects of multiple adverse events and grow up to be healthy, functioning adults who, in turn, raise healthy families and help communities to grow and prosper. There are a number of steps that the state of Ohio could take to assess the statewide burden of childhood trauma, identify affected children, and provide treatment to address the symptoms and reduce the long-term health impact of adverse childhood events. To be clear, these proposals are not specified in the state of emergency bill. Rather, they represent a roadmap of actions the state could ultimately undertake to address the crisis. 1, create a waiver or carve-out in the Medicaid program to address childhood trauma. The idea would be to have a Medicaid stream that pays for specified services for childhood trauma victims. That could include therapy, medical visits, and wraparound services such as substance abuse treatment, transportation, and case management. This would follow the pattern of other successful state Medicaid demonstrations, such as the Ohio Home Care, Passport, and assisted living waivers. Number 2, create an office within the Department of Health tasked with collecting data on the incidence and distribution of adverse childhood events, which would help policymakers to know where to target resources for greatest impact. The Department of Health could also carry out a public information campaign on childhood trauma so that more Ohioans are aware of the prevalence, impact, and the option of treatment. 3, the Department of Education could work with public schools to train teachers and staff to recognize childhood trauma and its impacts, so that kids are identified and treated rather than being labeled and punished for trauma-driven behavior. School personnel should be made aware of resources so they know where to refer children and families who need help. Number 4, the Departments of Health and/or Education could design and carry out a screening and early identification program. Early recognition and treatment has been shown to have an enormous impact on outcome of childhood trauma. And last, a comprehensive solution should include measures to improve safety, quality of life, housing, and educational opportunities in under-resourced communities, and address the social and economic disparities that affect communities of color. In order to initiate a planning process that will lead to effective action, we first need to acknowledge that childhood trauma is an ongoing crisis that affects hundreds of thousands of Ohioans. Declaring a state of emergency for childhood trauma would be an essential first step in bringing together government, academic institutions, organized medicine, and the community to work on addressing this problem. I urge the committee to support this bill, which, if passed, would mark the beginning of this statewide effort. I believe we can heal the effects of historical trauma and give a new generation a better chance. We have the knowledge, the skills, and the dedication here in our community and our institutions to lead the nation in this effort. Thank you.
Thank you, Doctor, for the testimony. The chair recognizes Representative Kleitz.
Thank you, Vice Chair. Dr. Seamus, I really appreciate the thoughtfulness that you put behind your testimony, and I am a parent of a child who's been through a lot of medical trauma, and luckily we've been able to have a lot of wraparound services, including, through his treatment at a children's hospital since he was born. He has 2 chronic illnesses, and he's a cancer survivor, and so I've seen firsthand how identifying a patient who has, especially a young patient who has had some trauma in their life, how providing them the right kind of resources can really make a dramatic change in how they move through their life with their peers. And so I know personally through our whole journey, it really took very little, from my perspective, of that kind of resources being available to him. And in the grand scheme of things, of a child who had 3 life-threatening issues before the age of 11, but having a psychologist that he regularly calls on was super important to him. So just wondering, in your research that you clearly have put together for this, can you give us some really concrete kind of ideas on what these resources would actually look like for a child who has maybe experienced some kind of trauma? Just a little bit of, I know you have it kind of outlined here, but like, what are we looking at cost-wise? What are we looking at in the way of the resources that could be available for a child, and what kind of impact that could have on a child?
Well, thank you. First of all, I appreciate your sharing that, Representative Kleitz, and I hope your child is doing okay now and has come through it okay. I'll tell you how, in some ways, the first way that this came to me and what got me involved in this issue was recognizing that, yes, for families like yours, for families like mine, where we've also experienced some of these things, even in our situation, it's not that easy to access resources to heal psychological trauma, and it takes a very involved parent, and it takes a lot of figuring out what the resources are. For people who come to me who are less medically sophisticated, who are less effective spokespeople and advocates for their kids, and who honestly have public health insurance, it can be virtually impossible. So you'll have a mom who knows that there's something wrong with her kid, who knows that there could be help. And you try to refer them to a mental health provider, and it's the community mental health center is the only one that takes their insurance, and it could be a 6-month wait, and then their appointment gets canceled, and it's another 6-month wait. And you can just, if you've lived through this with a kid, you can imagine what it would be like to be knocking on doors and trying to get help and just finding obstacles like this. So now, you asked what the implications and the cost would be. Just to be clear, what we're talking about now is the state of emergency bill, which doesn't have a cost figure involved. It's a statement of principle that this needs to be addressed. So I don't want people to think that they're voting. I'm sure you know that you're not voting on a spending bill. But ultimately, my sense is kids who have ongoing problems, adults who have chronic problems, are going to cost the system sooner or later. And to the extent that we can, find streams existing within Medicaid and sort of direct those streams to the kids who really need them and identify these problems early, then you're not going to see the costs that they incur later when they have their first heart attack at age 30, when they go through mental health and substance abuse treatment, half a dozen times, and all the various costs to communities and neighborhoods from, untreated trauma that leads to problematic activity and behaviors I didn't come prepared with a specific dollar and cents figure, but my sense is that this would be beneficial financially as well as to the community.
Quick follow-up. Thank you, Mr. Vice Chair. So to the witness, that's exactly kind of what I was looking for. I think that we kind of see these issues as something so big that how are we going to address them with a resolution or a state, declaring a state of emergency. But I think these are the conversations that can really come out of these situations, and just remembering that we meet the children where they are. And I think this is a very valuable tool that we can use in the state of Ohio to make sure that we are providing the resources where our children are and that they can benefit from that. And so I just wanted to, again, thank you very much for your work on this. And I know it's really difficult, and you hit on all the points that I think we're all struggling with that kind of see this for children that are struggling in the state of Ohio. So thank you.
Well, thank you.
Committee, further questions? All right, thank you, Doctor, for your testimony.
Thank you very much.
All right, the chair now calls Mr. Anthony Parker. Hello, Mr. Parker, welcome to committee.
Hello, good afternoon, and thank you very much for the opportunity to testify today. My name is Anthony Parker. I'm a second-year student at Ohio State University, and I'm testifying in favor of HCR.25. I first met Ronald Hummons last October during his hunger strike at the Ohio State House, where Dr. Yusuf Salam of the Exonerated Five spoke on behalf of this movement. And today I'm very proud to stand here with Ron and other members of the team after months of working on moving this resolution forward. I cannot stress enough how important it is that the Ohio General Assembly and the Ohio Health Committee pass this resolution. As someone who personally benefits from the systemic and institutionalized racism in this country, I'm here to say that there is a desperate need for state lawmakers across the country to declare a state of emergency on trauma and move forward on this issue. We need to recognize the historical repression of trauma on low-income and marginalized people, and we need to seriously think about the effects of 400 years of perpetuated trauma on Black and brown communities. When I think about that, I think about how my house in Canton, Ohio, is part of a historic, predominantly white neighborhood that was built for wealthy property owners, bankers, and lawyers, many of whom had servants during the 1920s. This trend of prioritizing development for investors continues today in my city, and needless to say, the kids in my neighborhood grew up with ample resources to aid them through life and deal with their personal trauma, but the kids who live down the street from me in low-income housing did not have these resources. My representative, Thomas West, was absolutely correct in saying that children, and especially children in communities of color, are suffering in their neighborhoods, in their schools, and in their homes because of the trauma that surrounds them. Children are born into a system where their success is determined by their zip code, and if you don't win the birth lottery like I did, you are prone to experience violence, neglect, hunger, housing insecurity, abuse, and other serious trauma in your early years. Just this year in my city, an 11-year-old boy shot and killed a 6-year-old boy, and yet this is normalized. We see this as a bad child that was raised by bad parents and did a bad thing, but nothing about this is normal. And the thought of children being exposed to and partaking in violence on a daily basis should send chills down your spine, not have you thinking that these are bad kids raised by bad criminals. Horrifying and sobering stories like this are a chilling reminder of the behavior that trauma and childhood trauma perpetuates in our communities. Unfortunately, our communities are not well prepared enough to deal with this trauma. Beyond the lack of material investment exists this racist stigma that bad children are in need of punishment. And instead, we need to realize that traumatized children need our help. Every year, My high school, when I was there, prioritized cracking down on bad behavior rather than addressing its root cause. And students racked up disciplinary charges and suspensions to the point where it prevented them from graduating. During my time at school, they increased security guard and police presence rather than increasing the presence of school psychologists and social workers, people who can help put these kids on a better path. This is but one example of the many ways that trauma is forced onto our youth. And if we continue to take a punitive stance on children who are in desperate need of mental health support, the future of our communities will be very, very bleak. It is time that we put a stop to the endless cycle of generational trauma. And while declaring a state of emergency won't solve everything, it is a necessary step that will set Ohio on track to deal with its trauma crisis. Thank you.
Thank you very much for your testimony today. Committee, do you have any questions of the witness? Hearing none, thank you very much for being with us today.
Thank you.
Okay, the next witness today will be Ronald Hummons. Ronald, if you would step forward for committee, please. Hi, Mr. Hummons. Welcome to committee today. You may proceed.
Chairman Lips, Vice Chair Holmes, good to see you again so soon. So my testimony today is going to be short. I felt it necessary to give credit to Representative Don Manning. It was his sincere compassion for mental health and childhood trauma that allowed my team the opportunity to make its first presentation for our initiative. I remember asking him what he thought after we unloaded a ton of information of the impact of childhood trauma. I wanted to get his feel because, I'm quite sure you know him much better than I do. He kind of gave a poker face as we were giving the presentation. But he responded. This is a no-brainer, and it's long overdue. Right away, he made a phone call to Representative West. That's actually what got the ball rolling to creating what's going to be labeled as historic legislation. Legislation is going to create generational healing for so many African American, poor white, Hispanic, and Appalachian children here in Ohio, and then eventually to the rest of the country. So I would like whatever results we accomplish today to be in remembrance of Representative Don Manning. I wish he was here today to see this because he was a huge supporter of this, and he was the very first to actually get the ball rolling for us. So I just want to end it with that.
Thank you very much for your presentation, Mr. Hummons. We've seen you a couple times and enjoyed your testimony. Committee questions? And I think everybody knows that he's referring to our former Vice Chairman, Don Manning, so thank you. That was a great honor. Committee, anything final? Thank you for being with us today.
Thank you.
Is there anyone else that would like to testify on House Concurrent Resolution 25? Anyone in the audience? Committee, I would like to also point out that there's written testimony on your iPad that I would like you to look at. And while you take that minute, committee's going back to recess for 10 minutes. And another exciting day here. I will note that I said 5 minutes is time and actually made it in 5 minutes. So I'm getting better on my timing. I want to point that out now that the GA is coming to an end. The next bill before you will be actually your first bill on your agenda, and that will be Senate Bill 258, which is a site compact from Senator Gavarone. You've heard a lot about compacts lately. Where's 258? Are there any members of the audience wishing to testify on Senate Bill 258? I think we've heard a lot about it. I think we understand the bill and we understand the compact at this point. I'd like to recognize Representative Plummer for an amendment.
Mr. Chair, move to amend.
Proceed.
Amendments 133-4057. Committee, this is actually our old House Bill 374, which we just passed out of the House, I believe, last week or so. It's the massage therapy bill that we passed out overwhelmingly with both bipartisan support. So this is not a new license by any means. It's just fixing a loophole where people were opening up therapy locations without the license, and they've turned into human trafficking and sex trafficking shops. It's been complaints from both townships and cities, mainly in my community. I'm sure in numerous other committees or communities. I've investigated these numerous times. They're very difficult to investigate, so this will close the loophole where the medical board can, oversee the license, and we can crack down and have a true, meaningful license instead of people circumventing the process. Thank you.
Thank you, Representative Plummer. Committee, any questions of the representative regarding the amendment or the bill? Is there a second to the amendment?
Second?
There's any objections to the amendment? Hearing none, the amendment is accepted and becomes part of the bill. What's the pleasure of the bill? Vice Chair Holmes.
Okay. So, right here, Mr. Chair, I move that amended Senate Bill 258 be favorably reported to the House Rules and Reference Committee.
Clerk, please call the roll call.
Chairman Lips.
Yes.
Vice Chair Holmes.
Yes.
Ranking Member Boyd. Representative Antoni. Representative Butler. Representative Carruthers. Representative Kleitz. Representative Catrona. Representative Ginter. Representative Grandel. Representative Keller. Representative Lepore-Hagan. Representative Liston. Representative Plummer. Representative Russo. Representative Swearingen. Representative Upchurch. Representative West.
Committee, by unanimous vote, you have voted to move Senate Bill 258, amended Senate Bill 258, favorably to the Rules and Reference Committee. That'll conclude the hearing on 258. Is there anything else to come before committee? This wraps up committee for this GA. I wanted to thank the members personally. You were wonderful to work with. There were days I would not have been able to make this committee operate or work or make any sense at all and achieve what this committee achieved. I personally would like to thank Representatives Ginter and Butler for mammoth contributions to the committee and to my learning experience as the first-time chairman of this committee. So, gentlemen, thank you. Representatives West and Representative Kleitz, you were tremendous, of a tremendous assistance to me. And I know you don't see Representative Boyd here, but believe me, she's been here. I can show you 10 or 15 texts today. So she's on the horn watching us. Committee, I could not be more proud of. You had 96 bills in Health Committee at one point, and you hung in there for some long days, and I am just so proud of each of you. I mean, here you've had to sit through 3 at-ease or recesses today, and you're still sitting here with us. So thank you from the bottom of my heart for what you helped us do for the citizens of Ohio. We're adjourned.